Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this video, I would like to discuss vasoactive agents for cardiovascular support on intensive care unit. First of all, I would like to explain the terms vasopressor and inotrope. We often use them interchangeably. In fact, they're a bit different. Vasopressor is an agent that increases vascular tone to give blood vessels a squeeze in vasodilatation states, like in sepsis, for example. On the other hand, inotrope is an agent that increases myocardial contractility to increase the force of contraction of the heart in low cardiac output states, such as cardiogenic shock. The choice of vasoactive agent depends on underlying pathophysiology and local guidelines of the hospital trust. We should ideally use a single agent, but occasionally drug combinations may be required. The aim of vasoactive agents is to achieve effective tissue perfusion rather than a specific blood pressure target. What I mean by that is we normally tend to keep mean arterial blood pressure, MAP, around 65. Here, we use MAP, which is the product of cardiac output and systemic vascular resistance, instead of systolic or diastolic blood pressure alone, because MAP is the better indicator for tissue perfusion. However, that MAP target will not be sufficient in patients who are hypertensive, who are having increased intracranial pressure, like in neurotrauma patients, or who are having abdominal compartment syndrome, such as in severe pancreatitis with ileus. Those patients will require higher MAP target for optimal organ perfusion. Before we commence vasoactive agents, we need to bear in mind that patient's circulatory volume is adequate, pH and electrolytes are reasonably corrected to ensure the maximum effect of vasoactive agents. So, let's start to talk about vasopressors. We should consider vasopressors when hypertension is not responding to appropriate fluid resuscitation, that is, after about 2 to 3 liters of crystalloids. If the patient is at high risk of fluid overload, we should consider vasopressors earlier than that. We commonly use vasopressors in patients on ICU with septic shock or refractory anaphylaxis, post-operative patients, and patients under sedation. The two main classes of vasoactive agents that we can use are catecholamines and vasopressin. Catecholamines, for example, noradrenaline, adrenaline, metronidazole, and ephedrine, are alpha-1 adrenoceptor agonists, which increase in systemic vascular resistance and divert blood away from the peripheries and gut towards the major organs like brain, heart, and kidneys. Adrenaline and ephedrine also have beta adrenoceptor activity, which is useful to counterbalance the reflex bradycardia caused by alpha-1 adrenoceptor activation, so unintended reduction in cardiac output could be avoided. Dopamine is not popular anymore because it is related to higher rates of adverse events like arrhythmia, according to studies. Vasopressin is V1 receptor agonist, and as its name, vaso is vessel, and pressin is pressor. We could consider it in catecholamine-resistant shock to reduce noradrenaline requirement. It can also be used in post-cardiac arrest ICU patients with hypoxic brain injury complicated by cranial diabetes insipidus. They could be having polyuria and struggling to achieve the target MAP to maintain the organ perfusion, especially if they are candidates for organ donation. In such scenario, vasopressin is particularly helpful to settle polyuria and improve blood pressure for optimal organ perfusion. Now, we can see how vasopressors work and how beneficial they are. As their indications and advantages, we need to understand their risks. Dysrhythmia is a common side effect due to increased myocardial irritability. It could be presented with tachy or bradycardia, especially with concurrent hypovolemia. Cardiac output could be reduced due to reflex bradycardia caused by alpha-1 adrenal receptor activation, as I mentioned above. Next, due to increased vascular resistance, cardiac workload could be increased with increased afterload. Moreover, vasopressors could cause myocardial ischemia as well as raised pulmonary vascular resistance, so we need to be very cautious to prescribe high-dose vasopressors in patients with cardiogenic shock or pulmonary hypertension without any inotrope support. As blood supplies are shunted from peripheries and gut towards the major organs during shock, another downside of vasopressors is splenic and peripheral ischemia, which could lead to bowel ischemia in patients with abdominal surgery, and also distal ischemia or tissue necrosis, especially with extravasation injury if small IV access is used. Now, let's discuss inotropes. We can consider inotropes in patients with heart failure, for instance myocardial infarction or cardiomyopathy. Myocardial depression is common in patients with severe sepsis, therefore we should consider using inotropes in combination with vasopressors. Inotropes can be classified as catecholamines, phosphodiesterase 3 inhibitors, and calcium sensitizers. Catecholamines such as adrenaline and dobutamine are inotropic mainly via beta-1 adrenal receptor activity, resulting in increased force of contraction and heart rate. They also have some beta-2 adrenal receptor effects, leading to vasodilatation and drop in blood pressure, which can be offset by adding a vasopressor, especially in patients with septic shock. Phosphodiesterase 3 inhibitors, for example mirinone and inoximone, inhibit phosphodiesterase in cardiac and vascular smooth muscle and increase levels of intracellular cyclic AMP, causing inotropic and vasodilating effect. They also have positive lusitropy, leading to myocardial relaxation. Since they have more effect on cardiovascular musculature, they are less likely to affect the chronotropy, which is heart rate, compared to catecholamine like dobutamine, and they're more suitable for patients with pulmonary hypertension. Calcium sensitizers, levosimendan for instance, work by sensitizing the myocardium to calcium and increasing contractility without increasing oxygen demand. Like phosphodiesterase 3 inhibitors, they have positive lusitropy, causing myocardial relaxation. There are risks associated with using inotropes which we need to be aware of. Arrhythmias, especially tachyarrhythmias, are common side effects usually when the patient is hypovolemic at the same time. Hypo or hypertension could occur depending on dominant inotropy or vasodilatation. Inotropes can increase myocardial demand and workload, therefore they could be related to angina chest pain or ST segment and T wave changes on ECG. Furthermore, catecholamines could cause abnormal metabolism of glucose and lipid via beta adrenal receptors, so could be prothrombotic and also generating lactate. Now, we have some ideas of indications, mechanisms, and risks of vasoactive agents. Then, I would like to discuss briefly how we should administer vasoactive agents. We can also check BNF and local hospital guidelines for details. During emergencies, to boost the blood pressure up quickly, we can give IV bolus of metronidazole from 0.5 mg per ml, ephedrine from 3 mg per ml if bradycardia is a concern, and adrenaline from 10 microgram per ml. In cardiac arrest situation, we can bolus 1 mg of adrenaline during CPR. Apart from these three, we don't normally give boluses of other vasoactive agents. Instead, we can give them via IV infusion for maintenance of target map and dose titration. Basically, if we can give IV bolus, we can use peripheral venous access. For maintenance IV infusion, central venous catheters are recommended due to risks of extravasation and peripheral tissue necrosis. If a patient is on a vasoactive agent, we need to monitor blood pressure invasively and more accurately via arterial line. In patients with cardiogenic shock, we should consider monitoring cardiac index, systemic vascular resistance, and volume status by pulse control cardiac output studies, also known as PICO studies. I will discuss how to manage patients with hypertension on intensive care unit in another video. So in summary, metronidazole, noradrenaline, and vasopressin are mainly for vasoconstriction to increase systemic vascular resistance. Adrenaline and ephedrine are also helpful for systemic vascular resistance as well as bradycardia. Inotropes such as dobutamine, marinol, inosmol, and levosimendan are more appropriate for enhancing cardiac output and heart rate. This is a bit about vasoactive agents we can use on intensive care unit. Hope this video is useful to you. If it is, please share with your friends and colleagues. I'll see you in the next video. Take care.